Thanks. Okay. Hey, everyone. So the point of this presentation is to kind of speak a little bit about exposure therapy, particularly as we apply it to OCD. Exposure therapy is a very great technique for other anxiety disorders. However, here I kind of want to focus on its application with OCD. So just a little introduction about me and the practice that I work in. I work in a group practice called My OCD Care. We're a team of about 6 psychologists with advanced training in CBT, ERP, SPACE, which I'm not sure if anyone's familiar with that, PMT, PCIT, CBIT, HRT, and MI. We specialize in OCD, GAD, specific phobias, panic disorder, BFRBs, which if you're not familiar are body-focused repetitive behaviors like trichotillomania, excoriation, dermatophagia, etc., tic disorders, and primarily with both children and adults, although I specialize with adults. 2 locations, but we are primarily virtual. I only see patients virtually at this stage. I would say 95% of my caseload are people suffering with OCD, typically from severe, moderate to severe, and even more than that. The Y-box scores of 24 to 37, which I'll go over what a Y-box is in the score and like what the significance of those numbers are. And typically people come to us once they've kind of been in regular therapy and it hasn't really been working and they kind of want something different. The goal that I'd like to get out of this presentation is kind of to make you guys proficient that they don't have to go to anyone else. And that's the goal. So briefly, I know this might be very basic for some people, but I just kind of want to go over the basics in terms of like what is OCD and kind of string together the different themes. Because I think once you understand the core of OCD, it kind of makes it very easy to, when we do the exposure, to attack the head of the snake instead of kind of playing whack-a-mole, which I think ends up happening all too often, and that doesn't help the patient. So with OCD, we start off, it's an anxiety-based disorder, but we start off with an intrusive thought, which everyone has. Those can be anything from like, I'm driving on a bridge and I think like, oh, if I turn the steering wheel, I could, drive off the bridge with the whole family. And I, who don't have OCD, would kind of not put meaning on that. And I would say, oh, that's weird, and then keep driving. However, someone who has OCD typically places meaning on an intrusive thought. And that kind of starts this cascade of anxiety buildup and then an attempt to reduce that anxiety, which kind of then is the whole cycle of OCD. So the intrusive thought will then lead to an obsession. Like, for example, if I turn the steering wheel, then I can go off the bridge. And then because you place meaning on it, it's like, oh my gosh, could I do that? Am I capable of doing that to my whole family or to me or to whatever the theme might be? And then because I put meaning on that, that's now a really big feared thing that I'm thinking about. So I build up this anxiety and then I want to get rid of that buildup. So I do a compulsion. The compulsion is an attempt to get relief. However, more often than not, in fact, I would venture to say, never does it help long enough. Never does it help without side effects. For instance, you'll end up spending way too much time doing a compulsion. You'll miss out on family events, social events, occupational stuff like that. And it can really be very detrimental to people. And we see how people really, really suffer when they start engaging these compulsions. This is a little graph just kind of to show the concept of like when you have OCD and you give into the compulsions, if you see here on the y-axis, there's something called a Subscore. I don't know if you guys can see it clearly, but it goes from 0 to 100. And a Subscore, if you're not familiar, stands for Subjective Units of Discomfort Scale. And it's between us, it's a fancy way of quantifying how uncomfortable this makes you. I personally think 1 to 100 is a little too broad, and it's hard to quantify the difference between like a 70 and a 73. So I usually do 1 to 10, and I think it's just a lot easier for patients to express themselves. In addition, if someone has like low IQ or hard to express themselves, easy, hard, medium, could also be a very good way for quantifying how, a SUD score. And the SUD score is going to become important as we get later on into the treatment. But if you see here on the y-axis, right, you have this increase in anxiety, and then the compulsion is initiated, which dramatically reduces the anxiety, however, only temporarily. And then it just keeps going, and you keep living with this, debilitating disorder that just keeps wreaking havoc on the person's life. If you employ ERP, then you see the steady decline in the anxiety, which is a very good thing because then you kind of lead to a sustained level of manageable stress or anxiety. And unfortunately, there is no cure for OCD. So it's really about management and symptom management. So that's why we want to help treat and train the person to be able to use these skills and employ them on their own. And this way, when they're out of therapy, they can still manage by themselves and not have to, spend time in therapy doing this. I want to talk about some themes. I'm not sure if everyone's familiar with these themes. If you have any questions about any of them, please just ask me. I'll explain a little bit about them. But you have relationship OCD, harm OCD, pedophile OCD, false memory OCD, existential, scrupulosity, just right. Sexual orientation OCD used to be called HOCD, but they've kind of moved to sexual orientation OCD, health OCD, which we're seeing a big uptick in with COVID, and contamination OCD. Any questions on any of these, or should we just kind of move past it?
I'm just quickly curious, like when this is how you're kind of helping to identify kind of broad categories of where people tend to land in terms of the content of their obsessive thinking, right? You're not making a distinct diagnosis here that like someone comes in, I'm diagnosing you with harm OCD, you're diagnosing with OCD and saying like that theme is okay.
Yeah, and then also the treatment is going to be pretty much the same. And that's kind of what I want to show you, that each of these, when the person first presents, looks really different. But when we kind of look at it from a specific lens, they're all very much the same. Therefore, the treatment is very much the same. And that helps us as practitioners not to be like nervous if it's one particular theme that we're not so familiar with, or if it's a theme that particularly gets us a little bit nervous, because the treatment's the same, the concept is the same. And even amongst themes, the actual common denominators are the same, which I think is really helpful for treatment. So let's move on to some differentials. I think that this is important to understand because, the treatment of exposure therapy could be a very bad treatment if you got the diagnosis wrong, right? So if, for example, if the patient has depression, but you're thinking it's OCD and you start doing exposure therapy, that might not be that helpful versus, another CBT modality, and vice versa, right? If the patient has OCD and you're treating it with a depressive modality or intervention, that also might not be really helpful. So I think it's important to kind of make sure that you have the diagnosis pinned down. I brought up some of the differentials here, but honestly, if we just boil it down, the concept is that OCD is ego dystonic. And that kind of is the real difference between OCD and all these differentials. So for instance, let's use depressive disorders, right, as a classic example. So someone with depression will typically say things like, I'm worthless, right? And they experience that thought as reasonable. They think they are worthless for X reasons that they can outline, and that's how they feel. However, someone with OCD, even with a thought like I'm worthless, it'll be ego dystonic. They'll say, I don't want to feel this way. I don't like feeling this way. I think that this is ridiculous or absurd about the thought I'm having or the action I'm doing. And that's a key difference, I think, in terms of differentials, that kind of shows you, hey, this is looking more like OCD. If the person says, I don't want these urges, I don't want these compulsions, I just feel like I have to do them. Versus, let's say, depression, it'll be, no, I want to do these things. This is what I think is, within the realm of what I'm looking to do. Same thing with hypochondriasis, GAD, forms of psychosis, and also eating disorders as well.
Ellie, can I just ask you, so sorry, is that the same for children and also in adults? That do children also, is it ego dystonic also for kids? They know that they don't want to feel that way, or
question?
That they should?
I think the answer is yes, but it might be harder for them to express that. So that often you'll kind of speak to parents and other collaterals to kind of get a picture of if they don't like doing it in the moment. For instance, if they're like, I really just want to leave the bathroom, but I'm too afraid, right? That would be like a great example. Did that answer you?
Thank you.
Okay.
Yes, thank you so much.
Sure. Okay, so in the interest of moving on, I think that's pretty much the point here. We could talk about specific things. I think that hypochondriasis we'll talk about a little bit later as well when it comes to like health OCD questions. So then we'll kind of jump back to that one. This is a QR code, by the way, for the Y-Box, which I believe is an awesome way of assessing symptom severity. If you want to just use your phone or whatever and click on that QR code, you're welcome to. But basically, the Y-Box is a Likert scale that assesses symptom severity, and there's also at the end of it a symptom checklist. The symptom checklist happens to be very helpful because a lot of times when you say like, oh, tell me about your OCD, the patient will forget about it. The patient will not remember that they used to have this symptom and they don't have that. And it's very helpful because it provides like a broad spectrum of common compulsions, common obsessions, and then you can kind of be like, oh, I used to do this one. And that'll help you when we talk about the core fear in terms of orchestrating exposures that will be helpful. When I spoke earlier about like the typical, score range that I see typically people who are 24 to 37, I would say, sometimes 40, but generally in the higher end of severe. And I put a picture just of what the Y box looks like, just so you make sure like you have the right thing. But essentially it's the 10 questions and you just rate it on a Likert scale, and it's very helpful for treatment. I usually do this right away, first session, maybe second, if like the first session intake and stuff like that, we're taking too much time. And then I'll use this as a tool to kind of assess how treatment's going, right? Like if we do a second Y box and a third Y box a month, 2 months in, and our scores are pretty much the same, then we have to change something up. And I think that this is a great way to keep us accountable. So we're going to move on to the actual therapy, which is exposure therapy. And the concept here, I think with exposure therapy is to kind of recondition the response. And we're treating OCD as a phobia kind of, and then what we're trying to do is recondition that response. So an example I often give is like, if someone has a fear of heights, right? Everyone says, oh, go to the top of the mountain and you'll be fine. And if you go up to the top of the mountain, look down and be like, oh my God, this is crazy, and you run away, then you really just reinforce the fear and you didn't do anything therapeutic. So the key here is that you have to stay with the anxiety until it peaks and then starts to wane. And that's where you start entering the therapeutic world. So it's very important to stress with the patient that they do the exposure and stay with the exposure until it's not as frightening as it was. That's very important, because otherwise we're not going to really be doing much in terms of therapy. I think that's something that some people kind of overlook, but that's very important. If you see this little picture here, it just kind of shows you how the anxiety does peak, but it goes away, and it's always temporary. It's never going to last forever. And that's something important for people to see. So I made up these 3 vignettes here, just kind of to use as a way to help talk about stuck points and some helpful tips throughout the rest of the presentation so that we can refer back to these patients. So I brought up 3 people. Michelle, who's a 30-year-old pharmacist. She's currently with her boyfriend, has been suffering with relationship OCD for the past few years, but she also now has OCD at work. And that one's much more debilitating for her. She's taking 3 times the amount of time to check the prescriptions that she has to do. And now she's kind of at jeopardy of losing her job. The previous therapist was kind of like afraid to deal with the work-related OCD, because that could be scary as a therapist to kind of prescribe things around misdosing people. So she tended to focus on the relationship component, which wasn't helping the immediate crisis. And obviously the patient really wants to keep their job. So that one is going to be important to talk about kind of what happened and how to help, which I think is a cool thing. And the next patient is Joy. She's a 24-year-old college student. She's suffering from OCD as well. She believes that she may have cheated on her test and plagiarized. So what she'll do is, after she submits the test, she'll email the professor 5 times and say like, oh, did you grade it yet? Or I didn't cheat, or things like that, to kind of seek reassurance from the professor. And she also will talk to her partner about that and kind of seek reassurance consistently. Obviously, she's getting on the nerves of the partner, and the professors are kind of suspecting that she is plagiarizing at this point. Sam is a 20-year-old entrepreneur. He's running a business with 2 friends, and he's suffering from contamination OCD. So with him, he only will use the bathroom at home so he can shower after he goes to the bathroom. He uses an entire roll of toilet paper every time he goes to the bathroom, and he'll use and not finish about 10 water bottles a day for fear that he may have contaminated the water if it was left out too long or something like that. And therefore, he'll just say, you know what, I'm going to use a new water bottle. And if you remember, in the height of COVID, toilet paper was expensive. So this was quite the problem. So I kind of want to show you how all these 3 patients present very differently, right? And if you look at them, they all look totally different. But in reality, there's one thing that kind of strings everyone together. I think this is the key when it comes to setting up exposures and doing good ERP. And that is that each patient has a poor relationship with uncertainty. And if you look at it, Michelle is afraid of the possibility of messing up at work, right? And misdosing someone. Joy is afraid of the possibility that she messed up in school, and therefore there's gonna be negative consequences. She'll get expelled, etc. And Sam's afraid that he won't clean himself enough and he'll drink something that's contaminated, he'll get sick. And all of them are uncertain of this thing, which then creates this anxiety. And in order to get rid of it, they're going to do a compulsion to try to reduce that anxiety. And what I think is ironic, which I think is important to see, and a lot of times patients will notice this as well, but like the thing that you're so nervous about, you end up doing these compulsions that kind of lead you to the same place. So for instance, Michelle checks and rechecks her work so many times that words look blurry to her, and she may actually mess up on the medication because 50 milligrams and 50 micrograms now kind of look the same to her. Joy will seek reassurance so many times that the teachers actually think that she's plagiarizing, and Sam will shower so much and go to the bathroom so much that he actually can get sick from that. So I find it ironic, and when patients see that, that kind of helps them be motivated to get good treatment, because like even the thing I'm afraid of, I'm actually going to get this way, I got to start doing something about it. And that can be a very helpful tool. So when we talk about constructing the exposures, it's very important to find what we call the core fear. So you'll have something that presents as a regular fear. So we could take any of the patients that we discussed, but let's take Sam, right? He's afraid that he goes to the bathroom a lot of times and he makes sure that he showers every time. So we kind of want to figure out, okay, what is the thing behind all of this, right? So a great thing that I start off with is, what are you trying to prevent? When you do a compulsion, right? Let's say taking a shower after you go to the bathroom, what are you trying to prevent? And that kind of starts you off on the road to find the core fear. So they'll tell you some generic thing like, oh, I'll get sick, right? And that's nice, but it's not a core fear. An example of a core fear is typically going to be something that boils down to permanent suffering. So for example, I'm worthless, I'll be abandoned, hopeless, I'll suffer and get sick and be in the hospital and die alone. You know, those are kind of the core fears. And when we talk about exposures, we want to bring out that core fear. We want the person to experience that fear this way until it subsides, as we mentioned before. This way, they kind of recondition that fear and they realize it's not as bad as I thought. And that's kind of the treatment. So if you find the core fear, then you don't have to play whack-a-mole, which is great. And then you can kind of go straight to the source, and that'll kind of domino effect into all of the specific compulsions that the person's doing. This is also very important, because once you have all that information, like, okay, I'm ready to do this, I'm going to start going. And most people end up going into like the world of triggers when they talk about response prevention. And I think that that's a mistake. I think that when you do an exposure, you're going to see a lot more results. So I just want to clarify the difference between a trigger and exposure. A trigger is something that naturally occurs with the patient, and that creates uncertainty or anxiousness. So for instance, Sam has to go to the bathroom, and now you're going to do some sort of response prevention. Sorry about that, guys. So if Sam says, okay, I'm going to the bathroom anyway, I'm going to use this as an opportunity to do response prevention, that's nice, but it's not as therapeutic as if he did an exposure. And an exposure would be that he generates something just to mess with OCD. And this is the point where the patient's able to go from a defensive position to an offensive position. And that's where we start seeing a lot of results when it comes to exposure work. And I usually use this like boxing example where you're in the ring and you're kind of just putting up your hands just to wait for the beating to be over. You're never going to win like that. The way to win is when you start throwing some punches as well. And when you start throwing some punches with OCD, then it starts running away. And that's where we see a lot of good results. So to kind of use specific examples for each of our patients here, let's say, for example, Michelle, right? So if she did a trigger, it would be she's going to work tomorrow and she's going to use that as an opportunity to engage in response prevention. And it's nice, but it's not as powerful as if she said, you know what? I have an extra client I'll take on, or I'm going to go help my colleague finish up her prescription checks or whatever it is. Now she's kind of doing something just to mess with OCD. She's taking the game to the offense. And that's where we're going to see a lot more results. Same thing with Joy. If she decides to do extra credit that she wouldn't have done otherwise, instead of just doing the assignment that she was going to do. They're both good to do, and you still should be doing response prevention with triggers. However, when we talk about therapy and therapeutic like space, the exposure is going to be much more impactful. Any questions on this slide? Okay, moving on. So when we talk about exposure, I think this is something that kind of gets people a little nervous. Like what can I put, like what's fair game when it comes to exposures? And as long as it doesn't violate these three tenets, everything is fair game. It cannot be illegal, it cannot be harmful, and it cannot be against the patient's values. And pending those are all good, then everything is fair game. And don't be afraid to try an exposure. If it doesn't really work, you tweak it and adjust as necessary. That's very important to get the ball rolling and have the patient start seeing some success. Even if it's not as powerful as you would have liked, but you're getting somewhere, then you're really doing something powerful and they're empowered to continue. And then you can also just, move along and adapt as you go, which is very, very helpful. There are people who say you got to find the core fear right away, and you got to, don't move until you do that. And I think that you're kind of holding the patient's therapy a hostage a little bit to that. And I don't think that that's as helpful as just starting and rolling with it and seeing what happens. And also starting slow, like we'll talk about low-hanging fruit when we get to the hierarchy form, which we'll talk about in a second, but working your way up is also very, very helpful. Instead of like, you prescribe something that's really intense for the person, they get scared and then they kind of say, okay, I'm not coming back to this therapist again. That was too much for me. Right? And now they're not getting help either. So I think erring on the side of a little bit easier in the beginning is very helpful until you kind of get to build that rapport and the trust with the patient.
You give an example of either like an SO OCD or relationship OCD where you have to like give an exposure, but you're making sure you're not against the patient's values to do that.
Okay. Let's see here. Let's take a SO exposure. So a patient has sexual orientation OCD. We'll say that the patient is heterosexual, and meaning like he's attracted to women. However, he has a fear that maybe he's attracted to men because he had what's called a groinal response. This is a classic example of SOOCD. So like he was ordering something in a restaurant and there was a male server and he had a groinal response. So now he has this intrusive thought of, hey, am I gay? And he says, I'm going to assign meaning to that. I'm going to obsess over that. And now because I'm so anxiety ridden, I'm going to not order from the server anymore. Right? I'm going to have my sibling or my family member order for me, and I'm going to turn my head and look outside the window. So an exposure that would be allowed would be this, it's within this person's values to order from a server, right? They'd like to be able to do that. So they're going to come, the exposure is going to be, you don't have to go eat lunch anyway, but you're going to walk into a restaurant, you're going to sit down and you're going to order a drink or food or whatever it is from the male server that shows up. And you're going to engage in a conversation with the person. Was that helpful?
Yes, I guess, except for the, like, will it expand to other things so that he then avoids other things? Is that enough of an exposure?
Yeah, I mean, again, you keep going until we build up fear, but you just don't want to cross into the territory of this is against the person's value. So for instance, if you have someone who believes that it's inappropriate to see certain things that they would consider against their values, right? So your exposure would never be to go see that thing or watch that thing or engage in that thing, even though theoretically it may or may not have been a good exposure, but it's off limits because it's against their values. So I'll give you a great example with scrupulosity that I think comes up with a lot of religious Orthodox Jews. So there's this rule that you can't mix milk and meat together. And if someone has scrupulosity, then they may get very nervous about having milk and meat together in the same house, eating it within a certain amount of time, etc. So a lot of people kind of tend to think, okay, so the gold standard here is going to be go mix meat and milk and eat it together. And I think that that's a grave mistake because that's not within the person's values. And they don't want to ever eat milk and meat together. They're just uncomfortable with the possibility of making that mistake. So therefore, they'll do other things that they don't agree with. So for instance, the patient will only use a water bottle for milk and a separate water bottle for meat. They know that that's against their values. They don't actually want to do that. They just want to not eat meat and milk together. But because maybe a piece of something I ate before is going to get in the bottle and now it's going to contaminate the other thing. So now that makes a fear. So the exposure would be to use the same water bottle because that's still within their values system, but it would not be to mix meat and milk together. Right? And the great thing about OCD is it's ego dystonic. So you can ask the patient, like, hey, what is within your value network? And what are you okay doing? What will be your goal here in treatment? Right? And if the person says, my goal is to be able to eat meat and milk together because, I'm going towards that end of the spectrum of religiosity, then that's a different conversation. But if their goal is not to do that, but to have more comfortability being, what they perceive as more mainstream, then that would be a great exposure. Okay, and then we can move on to the next slide. So This I really want to stress. I put a really pretty gold standard sticker here because I think in vivo exposures are the way to go. A lot of people who can't think of a good one or like get afraid of them kind of veer off into the world of imaginal exposures and scripts and all these other forms of exposures, which may work, may not work, may be okay, but in vivo is certainly the way to go. And there are times for other stuff. So for instance, with imaginal exposures, it's very helpful when you're talking about things that are harmful, like for example, a car crash, right? Obviously you wouldn't want the person to do that. Something that's illegal, POCD, harm OCD, something that's in the future, all those things kind of lend themselves really well to imaginal exposures. Virtual reality could be very good when it comes to things that are not practical, right? Like I'm not going to prescribe that this patient gets a plane ticket every week because we can't afford that, but we can do something that's virtual reality in that sense. Interoceptive obviously would be more sensational stuff, and that, you know, is a great move as well, but that could also be in vivo as well. But I do want to stress in vivo, in real life exposures are much better. So for instance, you can make a script of how bad life would be, or you could do the exposure that's going to make you feel like life is going to be really bad. And doing the exposure is going to be just much more helpful. And we'll talk about kind of some pitfalls with that a little bit later on. But kind of the way sessions work, it's very manualized in the sense that like session one is intake, rapport building, some history, you know, make sure your diagnosis is good. Typically, I prescribe a self-monitoring form, which is kind of just like a time slots, a Subscore, and an event note like section where the patient can kind of give me a picture of what their day looks like. That kind of just helps orchestrate better exposures. But kind of session two, pending that we got all the other stuff done, we'll start working on this thing called a hierarchy form. And I kind of, you know, explain it like it's a menu, like on a Chinese restaurant, right? You have a bunch of different things. I'll take a 3, a 5, and a 7. And those are going to be the exposures for the week. So you want to have this is going to be very collaborative, working with the patient, saying like, okay, what would be something that we can work on? Just let's put it on the board. Even if it's really hard, you're not doing it now, that's okay. Let's just get some things on the board. And we'll have things varying in score. I like using 1 to 10. So, you know, some 1s, some 2s, some 5s, some 9s, and a bunch of stuff in between. I like getting at least 10 or 11 to start. And then we can start with the low hanging fruit and we go higher and higher. And that's kind of the point. It's kind of like working out, right? You start with the 5 pounds. Once that gets good and comfortable, you move up, go to 10, 15, 20, etc. So here was an example of Michelle's exposure menu. So she would like to complete a drug check in 2 minutes. The norm is 1 minute. She's taking 5. So if she does it in 2 minutes, then that will give her a Subscore of 4. Let's say doing it in 1 minute would be even harder, right? That would be a 7 or an 8, whatever it is. Injection medications are really hard for her. She has a lot more meaning assigned to that in terms of the possibility of making a mistake, the severity of that mistake. So for her to only check an injection medication 2 times instead of 10 times would be a 7. And the same thing with her med cart as well, right? Like just leaving the building after she checks it and not coming in and sneaking in over the weekend with her key fob and rechecking everything over the weekend, that would give her a 9 if she didn't do that. And there are really sad stories, you know, where people really lost their jobs and stuff like that because OCD really impacted them. Like, you know, I heard a story, this was not a patient of mine, but I heard a story where it was a nurse who was afraid that like she would kill someone and dump the body in the morgue. And she would sneak into the morgue after hours to kind of check on you know, what damage she possibly had done. And she got fired because obviously the hospital couldn't have that. So these things are really, really sad and could be very impactful for people. And that's why it's important that we kind of go right away and start with a solution-focused approach. This slide, I didn't really know where to put this because I do want to talk about it. A lot of people describe themselves as having pure O, which I think is a misnomer. I'm a little bit of a stickler for this, but essentially what they're trying to express is that I only have the obsessional component of OCD. And I think it's a misnomer because it's not true. The person has a compulsion. It's just a covert one in their head. And they're still doing a compulsion, which is called rumination, but it's in their head. So they think it's obsessional, but really you have the C as well. It's not just the O. So I call it pure M or pure, you know, you can call it pure R or whatever. But the point is that the person's doing a compulsion. The compulsion of rumination is avoiding the uncomfortable feeling I have by pretending to do some problem solving. And it never yields to any actual problem solving. It's kind of just a rat on a wheel running in circles, and it's not helpful at all. So I think it's important to talk about, because this one I think is the hardest one for us to treat, A, and B, it's the one that we kind of have least information on when we think about treating it, versus exposures. We can set it up and we can do it and we can practice it, versus rumination is a little bit more ambiguous. So I kind of wanted to dedicate a slide just for this. But essentially, the goal is you have to accept the fact that rumination is not problem solving. That's step one. Because if you think it's problem solving, you're going to keep trying to do it because you think it's helpful. So the first thing would be explaining and disseminating that information to the patient to the point where they understand that. The next thing is they have to say, okay, as soon as I realize I'm in the world of rumination, I have to interrupt my cycle of thoughts. I have to stop doing this by pulling myself into something else that I'd rather be doing. And some people kind of say, well, isn't this, just procrastinating or just distracting yourself? But I don't think that's true. I think you're prioritizing your interests. And I kind of, describe it like this totem pole of interests, and rumination got superimposed to the top of the list because you have OCD. But if you didn't have OCD, or you had good control over OCD, you would not want to be sitting here ruminating, wasting 2 hours of your day. You'd rather go hang out with your friends, do your work at work, do whatever chores you had to do. And therefore, that's the thing we're prioritizing. So when you find yourself in a rumination cycle, it's not really what you'd want to be doing. You'd much rather be doing these other things. And therefore, we try to stop doing the rumination by quickly engaging in something else that you'd rather be doing. And it's important, obviously, that the thing that the person's going to do is not going to be something that's kind of, boring them, where they're going to just jump right back into rumination. You want this to be something that's engaging, right? So like a crossword puzzle is probably not going to do it. But let's say a video game where they're interacting with friends, or going out with friends to bar, karaoke, playing an instrument with a band. Those things, you're kind of going to be pulled into the other event, and therefore it's going to be much easier for you not to ruminate. But this one is a little bit trickier because the patient has to say, okay, I'm not doing this. I'm going to stop this, and I'm going to employ my other tool or tactic, which is a little bit different than, okay, I'm going to do this exposure and this response prevention. But essentially, it is the same thing. We're just trying not to avoid feeling uncomfortable, and we're trying to say, I'm just going to go prioritize something else.
Can I pick your brain on this for a second?
Yes.
So first question I have is kind of, what do you do in the context when you kind of provide that cycle and rumination is not problem solving, you're kind of getting to the point and the client either cannot or will not come to accept that idea? Right, because I have a lot of clients whom, for example, we will do that sort of psychoeducation. Yes, I get it. It's such a, okay. And then you assign the homework for the week is to go home and kind of do something different. They come back and I didn't do any of that, right? Like I didn't even begin to make the attempt on the homework. And it's like, why? Well, because I actually haven't really internalized this idea that I shouldn't be doing it to begin with.
Right. So what I would say is, first of all, it could be that it's a little too broad for the person. So maybe bring it into the session where a trigger that's going to cause this intrusive thought, which they're then going to want to ruminate. And then you practice doing something else in session. That might be very helpful, where you're teaching them kind of how to pull away from the rumination. And it's not versus a homework assignment. They either do it or they don't, and then it's over, right? They don't really think about it anymore. They don't have another opportunity to really do it. And it's much easier for them to just kind of push it away. But if you kind of force them to do it in session, then they're going to learn how to do it. And you're also there. So it's much more engaging than they're sitting on their bed, just trying not to ruminate and go to bed or something like that. And once they get used to it, it'll be a lot easier for them to do it in harder situations. For example, going to sleep. I think that's like the hardest part. It's like I'm ruminating, but I need to go to sleep, versus I can't just go up and go do something because I'm trying to get to bed. It's 1 o'clock in the morning and I have a full day tomorrow. So that I think is like the ultimate challenge when it comes to stopping rumination. So I would start off the slower version of in the session, let's say, with a smaller thing and work your way out.
The other question I have is, like, I was looking at your website and I saw that you also kind of use an ACT approach. So like an ACT, I think they would kind of argue, right, what you're trying to do here is not to distract yourself. And so there's always this kind of subtlety, right, in terms of, yes, you want to be engaging with an alternative activity, but you have to kind of frame it in the context of, I am acknowledging what is happening here and I'm choosing to kind of re-engage. I'm not distracting myself. And so I kind of wonder how you navigate that with the clients in practice. Like, you don't just want to train them to be afraid of rumination as a secondary.
Right. So I do try to ride the line, and I understand the question of like being afraid of rumination. I'm not trying to make them afraid. I'm trying to have them prioritize their interests. So a little bit different. And I understand it's a little bit of wordplay versus any substantial difference. I get that. But I think it is an important distinction. And if it doesn't work, or like they're not grabbing that, then you certainly can try the ACT approach. It also works really well, where like I'm leaning into it and I'm just going to say, yeah, this is the feeling I want to have. But ultimately, even with ACT though, at a certain point, you got to say, okay, but like I have other things to do now.
Right, for sure. Yeah, but I just said like the idea that you are, I guess that's the question, is how are you ensuring that you're kind of telling them that what we are doing here is making a conscious decision towards the thing that we think is important, and not simply trying to distract ourselves. When a lot of the preamble you're doing is saying distracting yourself is a tool that's going to increase the frequency of that response over time, because it's just another avoidance response, right?
Right, exactly. So because I look at rumination as avoidance, I'm saying don't avoid.
Right.
Right. But it's kind of like a little bit, I don't know, backwards word or like a double negative, but like what I'm trying to do now is engage in something different that I'd rather be doing versus a distraction. Right. It's a subtle difference, but I do think that the patient kind of understands that. Like, listen, I have all these things I want to be doing. That's why they're in therapy, right? Because like, I don't want to be sitting here ruminating. I want to go hang out with my friends, and I missed out on all these opportunities. So this is a way to kind of say, okay, well, then we're going to go do that.
Got
it. If I could just say, I wonder in those situations if it could also be helpful if the patient tells themselves, I'm moving on from this, like I didn't fix it. Like sort of like the, imaginal exposure, I guess, to whatever the worry is. Like if you're ruminating about a test or something, to say, no, it's still true. I might fail, but I'm going to play a video game anyway,
Exactly. Or sometimes, you can kind of pull in like, I'm going to royally fail. And there's going to be like the news article of me, like the worst test taker in history, but who cares? I did my studying for the day. I'm done. And now I'm going to go hang out with my friends or whatever it is. So yeah, I do think leaning into it also is very, very helpful. But then ultimately you got to stop, right? And you got to say, okay, I'm done ruminating. So those are all really helpful ways to kind of eject out of the rumination, which is a good thing. Okay. This one, gets a little bit, I guess, I want to be politically correct when we talk about exposophobia, but it's kind of a word used in the industry to describe like when a therapist is afraid to prescribe a treatment because they're not as comfortable with it. So they kind of lean into these other forms of treatment, which may not be as powerful. This is really important to kind of assess yourself, like, hey, am I not prescribing this because I'm afraid of doing it, or because I think it's not the right treatment for the patient? So I'm kind of going to use the same 3 patients that we've been working with throughout this presentation and kind of just show you a little bit about how that could have been a problem, how we're trying to change it. So Michelle's previous therapist, right, didn't want to take responsibility for Michelle misdosing someone. So, because that's really scary for her, right? She doesn't want to be in the news now. And like, that's very hard for her to deal with. So instead, she kind of was dealing with these imaginal exposures. Like, imagine that you gave the wrong prescription to someone and they died or whatever it is. And it's nice, but it's certainly not as impactful as doing an in vivo exposure where the person's actually saying, okay, I'm not going to be doing this thing that I normally do, my response prevention, and I'm going to move along and keep going. And the good news is, again, it's ego dystonic. So the person knows what they would like to do. So for instance, with Michelle, saying, okay, what's the industry standard in your business? How many times is normal to check a medication? Because that is kind of the job. And they say, okay, 2 times is normal, 4 times is normal, whatever it is. And that's kind of our goal now. That's where we're headed for. We're not headed to just arbitrarily hand out medication to patients. That's not the goal. The goal is to do whatever is normal in the industry. And I think that's and once you understand that, it takes away a lot of the fear of the prescribing exposures, right? Once we understand, okay, listen, I can rely on the patient to explain what's normal, what's not normal. And that could be very helpful. Same thing with Joy, right? She was writing scripts of how bad life would be if she was expelled. However, she wasn't actually doing anything to say, I'm going to try this thing in real life. So once she started doing these extra credit homeworks and stuff like that, and she was really putting herself out there with a real exposure of, I'm going to do this assignment that I don't have to do, and I'm going to prevent my response of seeking reassurance, then she started making a lot more progress with her therapy. Sam, I kind of brought a different example, which was that initially he would tell himself, okay, so I know that this water bottle is clean, and because my thought is crazy, and therefore I'm going to drink it anyway. And the therapist is like, okay, awesome, right? We're tackling this. He's going down in his water bottle use, but he wasn't really going down in anything else. And I think the difference was because if you look at what Sam was saying, he was saying, I know it's clean. And he wasn't really confronting the uncertainty part. And that's the part that we really need to change. He has to be more comfortable being uncertain, more comfortable being uncomfortable with that. And when he started saying, it might be contaminated water bottle, I just don't care, I'm going to drink it anyway, that's when things started to move along, versus saying, I know it's clean. I saw that the bottle, nothing happened to it and things like that, and trying to convince themselves that they know it's clean. That doesn't really help, because we're kind of just avoiding that one situation, but we're not really doing any progress. Versus, saying, I'm going to invite that uncertainty, or I'm going to contaminate the bottle on purpose, right? And that kind of goes to this point of like, people with OCD often trade convenience for certainty. And this is like a big deal. So someone who doesn't have OCD says, listen, yeah, everything could happen. I could get sick from touching the guard, the rail on the way to the subway. Just like, I got to go to the subway, the rail's right there. It is what it is. And I'm just going to touch it and move on. But the person who has OCD may say, well, I don't want to be uncertain about that. And I don't want to maybe get this disease. So therefore, I'm going to trade my convenience, and I'm going to put on a glove or a paper towel or whatever it is. And I'm going to do something that's a little bit more inconvenient for me. The problem is that keeps building and snowballing into just a really hard life for the person, to the point where they say, okay, I got to stop this.
I got a question for you. For situations where maybe you can't recreate something, for example, like a student that might have a fear of a bloody nose or vomiting or something like that, could you give an example of those, of how you kind of expose?
Sure. So let's take a metaphobia. That's a great one. So metaphobia is where they have a fear of vomiting. So like the patient wakes up every day and like, oh, today's the day I'm going to puke all over the place, right? Today's the day. And they get all nervous. And I'll give you a classic, college student who wants to go to college parties where they're going to be exposed to throw up. And that's really nerve wracking for them. And now they avoid the party, etc. So the first thing I generally do is, what we do is something called a vomit recipe. And what we'll work on is making the person interact with fake vomit. Now, sometimes that's a little too hard to start with. So we'll start with like a cartoon or a meme of vomit. And the person will start watching that, getting more comfortable with that, and then work our way up. I remember this one video, it was so, like, I was going to throw up, and I got to turn off the camera at points where, it was just vile, but the patient was able to sit there and watch the whole thing. And then we moved on to a vomit recipe, which the best vomit recipe is mixing acid and milk. And then you kind of put some other stuff in there, and it is quite gross. But let's say oatmeal, milk, and lemon juice, and they mix it up and they put their fingers in it and they touch it and they, expose themselves to feeling that throw up. And then you work your way up to the point where you're able to do some items, like, for instance, spinning in a chair where you may throw up. The goal, I don't think the goal is to get them to throw up. I think the goal is to get them to accept that they may throw up. And if that doesn't work, then, maybe some last resorts of getting them to actually throw up might be an option, although I think that should be really, really seldom used. But let's say, for example, the patient says, okay, I'm going to spin around this chair and I may throw up, I may not throw up. I'm okay with taking that chance, which is the thing that they were avoiding the whole time. So I think in that sense, it's a job well done.
Thank you.
Sure. Okay. So some stuck points. What should I do if these are 3 questions I think a lot of people would like to have answers for? So 1, what should I do if my patient's not doing the exposures? Like, I'm sitting here and I'm racking my brain. I came up with some good ones. I prescribed them, and then like they fall flat. So generally it's a little too hard for the patient. That's usually a sign that's a little too hard for the person, because they do want to get better. They do want the treatment, but that might be too much for them. So what I would say is, you could consider micro exposures, which would be very, like, instead of saying, okay, we're working on exposures and then we're going to go to another exposure to fix the OCD, we're going to say, within that exposure, I'm going to go from one small piece of it to the next one. So for instance, if someone's afraid of going out to the supermarket, so the first job of the micro exposure would be get dressed, get out of bed, go to the front door. That's it. And then the next day, grab the doorknob, turn it, open it, and that's it. And then you work your way up. So that might be a little easier for the person. And that could be a reason why they've been avoiding doing the exposures. This one's a little bit of a dirty trick, but it works really well, where you go so slow and like prescribe things that are like really easy for the patient that they kind of ask you for more. And that's a really, really helpful technique. The other thing is reducing exposure items to lower Subscores so that it's a little bit easier. So instead of a micro exposure, you can still do exposures, but just that are not as hard. So for instance, which this will lead us to another point that I'm definitely going to bring up, but You know, having a mediocre exposure with a really good response prevention is far better than a really good exposure with a mediocre response prevention. So for example, let's say this person's afraid of going to the bathroom and using the flusher with their hand, and they normally use their shoe. So you can say, okay, listen, we're gonna do a really good exposure and you're gonna go touch something that's even worse than that, right? Like stick your hand in the toilet bowl. Then they end up washing their hands for 3 minutes with soap. That wasn't really that helpful. But if you say, okay, instead of using your shoe, you'll use a tissue to hit the flusher, but you're not washing your hands at all. That I think is much more helpful for the patient. And then you can work your way up towards that. But the goal is to have good response prevention, much more so than anything else. And then the second question would be, what should I do if my patient spends the whole time seeking reassurance? This can be very, very tricky, especially if the patient's talking a lot and you can't get a word in edgewise. That can be very tough. So what I generally try doing is sometimes you have to be a little bit rude for the first time, but I generally try to provide some education with like, okay, this is the concept here, right? With the certainty and uncertainty, what you're trying to do is gain that certainty. That's not helpful for you. And I really want to be helpful for you. So that's why I don't think it's a good idea to do this. And then you're kind of left in this position of, okay, well, if the person does it again, how do I bring it up, right? And I think that that's important to say, listen, I don't want to be rude. Let's come up with a system that the way you want me to approach this. How do you want me to deal with a situation where I see that you're seeking reassurance and we're not really progressing with the therapy agenda for the day? How do you want me to handle that? Usually you get a decent answer. Sometimes if that's not working, I'll say, listen, you know, we can do supportive therapy, or we can do solution-focused therapy and like explain the difference between the two, the value of each. And if they're not ready for it, they may not be ready for it. And then supportive therapy might be okay. But generally they'll be like, okay, I want the solution-focused therapy, and let's do it. I'll come up with a game plan when I'm seeking reassurance, say, you know, our code word or whatever it is, and then I'll stop, usually. What should I do if my patient has other anxieties in addition to OCD? What do I prioritize? So I think this is a really good question. Obviously, I first say use a collaborative approach, speak to the patient, right? Like, what do they think is more preferable for them to work on? So I just had a patient recently, actually, who has like social anxiety and OCD. We said we're starting with OCD. And then she's like, well, listen, my job now is involved a lot more situations where I really want to work on the social anxiety. So let's change up our therapeutic goal. And that's fine. But if you're kind of, you know, it's 50-50, then I typically lean towards OCD treatment first, just because it's much more like manualized, solution focused, orderly, and it's a lot easier to gain the skills of response prevention. And then you could kind of expand that to all the other versions of the anxiety that the person's suffering from.
I have a question.
Yes.
Sorry. Is it ever that people are being like taught for more adaptive, like coping to the anxiety, or is it always that they need to just experience the anxiety without doing anything?
Meaning like other coping skills, like breathing techniques, things like that. Is that your question?
Right. Like instead of washing the hands, it's like they experience the anxiety and then they're taught like a more helpful way to cope with that versus, no, you just have to ride it out and experience that it gets better.
Good question. I'm leaning to say ride it out, simply because you may not have these really good techniques for all of their themes. I think it's very good to have good skills for anxiety reduction. That's true. And that's great to employ whenever possible. But like the person's goal when they come in for OCD treatment is generally going to be not to do the thing I normally do. And replacing that with another thing that I have to do may not be that helpful. So I think the goal for OCD is prevent the response that you normally do. And also here are some really helpful things to do when you're feeling anxiety in general, versus like, okay, when you have the fear, the particular fear of contamination, instead of washing your hands for 3 minutes, do square breathing, right? Like that may not be that helpful because you're just basically replacing one compulsion with another, essentially. Does that make sense?
Yeah, definitely. Thank you.
But I do think those are all great things to use as more of a broad approach to like stress management and anxiety. What do I do if it's a rational fear? This got its own slide because this was one of my brother's questions. So it got its own dedicated slide. But health OCD, I think, is a classic example of like, hey, that's kind of a good point. So someone wants to work out and go exercise, but they get palpitations and then they get really nervous that they're gonna have a heart attack. So that's kind of like a good point. And you don't want to say, oh, don't worry about it, go do exercise, and the person has a heart condition, and you're kind of responsible for some bad things. So what I generally do is I say, listen, you get one free compulsion, go to the doctor, get yourself checked out, and then we'll go from there. If the doctor says you have a heart condition, fine, you have at it, you can compulse away and not exercise. However, if the doctor says you're fine, let's say, and come back in a year, then we treat it as normal. And then, you're done. And now you agreed beforehand, before you went to the doctor, that if you got the clean bill of health, we're going to treat this as regular OCD and use regular ERP. The other thing that I think is just a kind of a good point to understand with health OCD specifically is like, the patient is putting a particular amount of importance on this one health concern versus any other health concern. And that's, kind of very arbitrary. And when you explain it to the patient, they kind of realize, okay, fine, like that's a good point. Like I just made up that this is going to be the particular issue that I want to hyper obsess about versus any other thing. And I don't find that there's this problem of like, oh, now I'm going to obsess over everything. Generally, that doesn't happen. Generally, it's like, okay, let's deal with this one problem. And then you kind of move into, okay, let's get you checked out, get a clean bill of health, and then we'll treat it like regular ERP stuff. And again, I'm going to say this 1,000 times, but OCD is ego dystonic. So you could rely on the patient, which is really, really helpful. Say, like, what is your goal here? What would you like to do? And we'll use that as the therapy goal as well. Some helpful tips. So I put together, these are the things that I think kind of separate the basic practitioner from someone a little bit more advanced with this stuff. And hopefully this will be helpful for everyone. So anxiety, this is an important thing to remember. Anxiety doesn't ruin the patient's life. The compulsions do. And if the patient thinks that the anxiety is ruining their life, then they're going to keep trying to get rid of the anxiety by doing compulsions. And that is not going to be in their best interest. So when they realize, hey, listen, anxiety is just a feeling that I'm having that's temporary, but the compulsion is this ritual that I'm kind of a slave to, that's ruining my life. That's what's keeping me away from my family event or my work meeting or whatever it is, then they're much more willing to engage in response prevention, which is really, really helpful because we do want buy-in from the patient because they're doing all the work. And it's very scary to kind of confront all these fears, especially when we're talking about a core fear, right? So we want to put them in a position of success. The other important tip, I think, is going towards anxiety, not away from it. The thing I always tell patients is if OCD says yes, Dr. Felt says no. And if OCD says no, Dr. Felt says yes. And that's kind of the mantra of like, I just had a patient the other day who's like, yeah, doc, I wanted to go back and check the stove. And I'm like, oh, I want to do that. Okay, I'm leaving the apartment. I'm going to go do something else. And that's kind of just going away from the compulsion that you want to do and going towards the thing that's going to create that uncomfortable feeling. Empowering the patient to succeed by dismantling. This one is a very important tip. At least I do. I don't know about everyone else, but like I always look for the thing that went wrong and we dismantle it, figure out what went wrong, how can we change this, what are we going to do about it? But you have to give the same weight to what went right. And I always say like wins equal wins when it comes to OCD. And the more success we have with response prevention, the easier it is for us to do it again and again and again. And therefore we want to figure out like, oh, I got a good night's sleep last night. So therefore when I had anxiety, I was able to handle it much better and I was able to employ the response prevention. That's a great thing to know. So, the day before, that you're gonna have a bunch of triggers, maybe make sure to get some good sleep, etc. I think that's a really helpful thing to focus on. Another thing is intrusive questions. This one's a very good point. Intrusive questions, they may be valid questions, but you don't have to answer them right now. And that's an important way to kind of help a patient kind of sidestep the rabbit hole of OCD where they start going down this what if pattern. And we say, it's a good question. It could be you are a murderer. It could be you will get contaminated, but we don't have to deal with it right now. Right now, your goal is to finish the meeting or to finish the job that you're doing, whatever it is. And therefore, we're going to sidestep that question. I use some analogies for this as well, kind of to explain how like there are valid questions. They're just not prioritized right now. Like a typical one I would use is, taxes and tax returns are really important, but until April, you don't really think about it. And it's still a valid thing to deal with. It's just not on my priority list right now. A couple more helpful tips. So doing exposures during the session, which I alluded to before, is I think the most impactful exposure therapy that we can do because you're able to help the patient there in the moment. And that can be much more helpful than prescribing the homework. The homework is still very good and important and that you want to kind of stretch what you do in therapy to the rest of the week. But doing them in session versus just like spending the 45 minutes talking about other things is not gonna be as helpful as doing the exposure. So even like I'm virtual, so it's much easier for me to do exposures with the patient in session. But if you're in the office and the patient has contamination OCD, you can do things like, okay, now you're gonna go to the bathroom, you're gonna press the flusher, you're not gonna wash your hands, and come right back into the session. And things like that might be very helpful for the patient, not being afraid to do things in session. And we're getting to the end, which is good because we are just about out of time. This is the last like clinical slide. So this one is very good for perfectionist or just right OCD themes, which is like, have the patient do a secret exposure, where a lot of times you'll find that the patient's concerned with, am I doing the right thing exactly the way the therapist prescribed? And what if I messed it up a little bit and then I lose hope and I kind of lose the motivation the rest of the week, and that kind of falls on loses all of its momentum. So what I typically will do is say, okay, you have to choose your own exposure. Don't tell me what it is. Choose your own response prevention. Don't tell me what it is, and just go do it this week. That's your job. And that can be very helpful because what you're doing is you're bringing the uncertainty into the actual exposure. Spoiling a compulsion is a very good one. So for instance, like a patient will be like, hey doc, I tried to go into the bathroom and I pushed the flusher, but I ended up washing my hands, right? So instead of that being like, okay, oh, well, okay, go back in and do it again, because you can harness and leverage that feeling of like, oh shoot, I wish I did it. And then you can say, okay, turn around and go do it again. And we spoiled the compulsion and we reintroduce that exposure, that uncomfortability. That could be a very good one. This one I always mention, which is don't forget the response prevention part, because if you're just doing exposures and there's no real response prevention, you're just living with OCD. You're not getting anything therapeutic out of it. And we spoke about like mediocre exposures with amazing response prevention is much more helpful than the other way around. The other thing I kind of tell patients is like, think of ERP as like your vitamin, daily dose of vitamin. You need 500 milligrams of vitamin C every day. And you also need to have X amount of exposures every day, where you have to constantly be in this mode of being on the offense with OCD. And when I say this, I'm talking about exposures much more so than triggers. And I know we're out of time, but I would be remiss if I didn't mention things I love about working with patients with OCD. And I love that patients with OCD are genuine, hardworking people who are often so concerned about harming others that generally all the themes are about, I'm going to hurt someone else, I'm going to do something bad to someone. OCD sufferers don't want the urges they have. So I love this one. We can be humorous about them. We can be candid because they know that it's ego dystonic. Patients with OCD are willing to work really hard to get this under control, which I love. And my favorite one is when like the concept of ERP clicks and they kind of accept it, and you see that wave go across the patient, and then they move really fast. On average, I would say most of my patients are 20 to 24 sessions. I've had much less than that. I've had longer than that as well. I think that I am not going to pretend like I didn't, but on average, I would say 20 to 24, because we're very solution focused. We don't really focus on like flavor of the week therapy. Typically, a lot of my patients are seeing a regular therapist for other issues, and this is just OCD treatment. So that gives us the luxury of just like honing in on OCD. And like, I'll generally work with the other therapist and say, okay, I'll take care of the OCD stuff. You deal with the other things that the patient's dealing with. And I just get to, focus only on OCD, which gives me a lot more success with it. And lastly, the famous question slide.